Good morning, everybody. Let's get started. Let's start with some announcements. First of all, welcome to this today's Grand Rounds, very special Grand Rounds. First, some announcements. Upcoming Grand Rounds on June 2nd, we will have two of our former postdoctoral fellows come and present. The first one is Stephanie Marhevka. She will be talking about meeting people with HIV in the southern US, where they are, a developmental journey. So it will be an overview of her work after graduating from our program. And the second speaker will be Jose Bauermeister, who will be talking about designing HIV prevention for young sexual minority men, behavioral congruence in the era of next generation PrEP. So that's the Grand Rounds on June 2nd, so two alumni. And then on June 23rd, we have the last Grand Rounds of this academic year. Very special speaker again, Ken Mayer, who will be talking about the next generation of PrEP. And the question that he will address is, what will it take to get it to scale? Those are upcoming rounds. Anybody else who would like to make an announcement? If not, then I'm going to introduce our speaker for today. Our speaker for today is Dr. Valerie Earnshaw. She is a social psychologist, and she received her degree in 2011 from the University of Connecticut. And currently, she is an associate professor in the Department of Human Development and Family Sciences at the University of Delaware. Dr. Earnshaw studies stigma and health inequities, particularly within the context of substance use disorders and HIV. And the focus of her research is understanding how stigma and health inequities are associated, but also how they can best be addressed. She is a recipient of some major awards from the American Psychological Association. She is involved in a lot of research projects, and of course, she received several grants herself. Her work has inspired the thinking and the research of a lot of scholars, including that of ours. And the main paper that she wrote in this respect is From Conceptualizing to Measuring HIV Stigma, a review of HIV stigma mechanisms and measures, and it was published in AIDS and Behavior. That paper is cited almost 1,000 times, and reviewing her CV, it turned out that this was the very first paper that she published. Well, that's pretty remarkable. So I'm very pleased that she was willing to come today and talk to us. The title of her talk is Substance Use Disorder and HIV Stigma, Key Concepts, Findings, and Intervention Strategies. Valerie, welcome, and the floor is yours.
Thank you so much, and thanks for that kind introduction. I see a lot of familiar names, some older friends and some newer friends on the attendee list. So thanks to everyone out there who's joining. I know it's a busy time of year, and I'm really excited to connect with you all. So I'm going to go ahead and share my screen. See my slides. Okay, and I am opening the chat box in case Theo needs to tell me that I have gone too long. So hopefully we're good to go. Okay. So once again, a big thank you to Dr. Sanford for the invitation to join you all today and for that really generous introduction. I very much admire this group's work, and I'm excited to connect with you all. So I'm going to start us off today with a brief overview of stigma, and then I'm going to summarize some findings on substance use stigma and HIV stigma, and I'll wrap us up with some work on stigma interventions. And I'll use this bar at the top of our slides to orient us as to where we are in the talk. So starting off with our stigma overview, I'm going to share some definitions and relevant theory, really just to provide some common context for the findings that we're going to be discussing. And I won't spend a lot of time with definitions because this audience is full of experts. Many of us are quite familiar with these concepts. So I'll just briefly mention that theorists describe stigma as a social process that emerges at the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination all happening within a power context. And this social process results in some marks, characteristics, or identities, like substance use disorders, being constructed as indicators of a tarnished character, or certain people being seen as less than or worse than others. So when I use this term stigma today, I'm really referring to this big, broad social process. And this audience is also aware that, unfortunately, we have many examples of marks, characteristics, and identities that are socially devalued and discredited. So I'm focusing on two of these health-related characteristics today: substance use disorders and HIV, but there are rich literatures investigating stigma associated with other characteristics such as race, sexual orientation, gender, and many, many others. In the past, much of our research on and interventions to address stigma, and especially health-related stigma, occurred within disease silos. So we would have fields of research focused on substance use disorder stigma, HIV stigma, and other forms of stigma. And they didn't always have a ton of overlap, but there has been pushback on this. And I think it's that pushback has been gaining momentum in recent years. So theorists have highlighted that the theories that we use to understand stigma, the research methods that we use to study it, and our intervention approaches to change it are actually quite similar across these disease contexts. So to make meaningful strides in understanding and addressing health-related stigma, there have been calls for researchers to deconstruct these existing disease silos and try to use cross-cutting approaches to stigma research and intervention. And this was the focus of an NIH and Fogarty-sponsored special issue on cross-cutting approaches to health-related stigma research that was published in BMC Medicine in 2019. But one of the things that this cross-cutting approach to stigma research allows us to do is to think about the processes linking stigma with health outcomes among individuals across a wide range of disease contexts. So this would include substance use, HIV, as well as others. So we start this social process of stigma, or we start with the social process of stigma that we've been talking about. And then our framework suggests that this social process of stigma is manifested, or it's expressed and it's experienced within structures and among individuals. And I like to focus on these stigma manifestations because they are measurable and they are changeable. So broad social processes like stigma are difficult to quantify, but we can quantify stigma that is manifested within our structures and within people or individuals. So we can use surveys and scales to do that. And stigma manifestations are also changeable. So we have evidence-based intervention tools that we know can either reduce stigma manifestations or protect people from them. So stigma manifestations exist at multiple social ecological levels. So I'm just going to briefly review a few key terms because I'm going to keep using them throughout the talk, and different stigma researchers use different terms to refer to these concepts. So I'll just share the terms that I'm going to use today. So structural stigma is defined as societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being of the stigmatized. At the individual level, so among individual people, we often differentiate between perceivers and targets. Perceivers being people who don't necessarily live with the stigmatized characteristic themselves. Sometimes we're thinking about how they might be perpetuating stigma. So sometimes this includes medical doctors, employers, coworkers, friends and family members, or community members in general. Perceivers may endorse prejudice, which are those negative emotions or attitudes, maybe like disgust or pity. Stereotypes, which are group-based beliefs that are often applied to individuals. And then discrimination, which is poor treatment of individuals. And then targets are the people who are living with the stigmatized characteristic themselves. So targets would include people living with substance use disorders and HIV, and they may experience internalized or self-stigma by endorsing negative beliefs and feelings associated with the stigma and applying that to the self. They may experience enacted or experienced stigma, which includes experiences of discrimination in the past or the present. And they may also experience anticipated stigma, which refers to expectations of discrimination in the future, like expecting to receive poor care in a medical setting. And as Dr. Sanford noted, much of my work actually has dealt with how do we measure these separately, and then what do we learn in our research when we measure them separately and try to map them onto different types of health outcomes. So Hopefully we'll be able to preview some of that within today's presentation. If we return to this figure, these experiences of stigma are in turn associated with a suite of mediating mechanisms, which are really just the processes that link our experiences of stigma with our health outcomes. So stigma manifestations undermine access to resources. So for example, they prevent people from accessing treatment and jobs, they compound social isolation, and they lead to psychological responses like depression, stress, and avoidant coping. And then together, our mediating mechanisms can lead to substance use and HIV. They can undermine outcomes among people living with substance use disorders and HIV as well. It's also critical to note that people with substance use disorders and who are living with HIV are a diverse group. So intersectionality theory highlights that all people live with a range of intersecting characteristics or identities, and these represent both dimensions of privilege or power, as well as of vulnerability. And the theory holds that these characteristics can lead to unique experiences for individuals, including experiences related to stigma. So stigma intersectionality theories tell us that to really understand how stigma is experienced by individuals and how it impacts their health outcomes, we need to study these different dimensions simultaneously and in an interactive way. So this means that people's experiences of substance use disorder stigma or HIV stigma are shaped by their substance use and HIV status, but also many other things. And so we'll be revisiting this idea throughout the talk. Okay, so let's turn to research on substance use and stigma. So I'm going to summarize some of our findings on stigma and substance use related outcomes at each of these social ecological levels that we've introduced. So at the structural level, the war on drugs is perhaps the most commonly cited example of structural stigma when we're thinking about substance use. So these policies are critiqued as treating people with substance use disorders as criminals rather than people with chronic illnesses, and they lead to increased risks of incarceration, which can have tremendous impacts on people's health and recovery. And an additional example, though, is barriers that exist to prescribing or accessing evidence-based treatment. So the X waiver has been identified and critiqued as a form of structural stigma in this space. So as you know, US law requires prescribers to obtain a waiver, the X waiver, for outpatient prescription of buprenorphine. And these policies are changing and hopefully will continue to change, but this X waiver continues to be critiqued as restricting access to a life-saving medication. This figure is from a paper by Jones and colleagues, and they highlighted counties with at least 10 or more opioid overdose deaths. The ones in green are the ones that also had one or more buprenorphine provider, and the black ones were counties with no providers. And the authors highlight a sort of geographical disparity or a treatment access desert, these places in the South and the Midwest where opioid overdose deaths were happening at the time, but access to buprenorphine is limited. And these data were pre-pandemic, so I expect we'd see, a lot more green and black dots over a map like this today. Related to intersectionality, racial residential segregation is one of our most well-studied forms of structural racism. It's a legacy of redlining, Jim Crow laws, and slavery. Godel and colleagues did this really interesting study where they found that indicators of racial residential segregation were associated with access to methadone and buprenorphine. So the figure on the left shows access to methadone, whereas the figure on the right shows access to buprenorphine. And they essentially found that facilities providing methadone were more likely to be in segregated African-American and Latinx counties, whereas facilities providing buprenorphine were more likely to be in segregated white counties. So essentially, they're finding that where one lives, which is fundamentally shaped by residential racial segregation, a powerful form of structural racism, shapes access to the type of medications for opioid use disorders that people can access. At the level of the individual perceiver, again, people who don't necessarily have a substance use disorder themselves, researchers who have studied prejudice, that affective or feelings component of stigma, have found that prejudice towards people with substance use disorders is characterized by contempt, and it's experienced as feelings that express moral outrage. So this would be things like anger, disgust, hate, and blame. Stereotypes, that cognitive or belief component of stigma, are characterized by perceptions that people with substance use disorders are dangerous, unpredictable, responsible for their condition, and not capable of decision making. In terms of discrimination, research has identified and characterized discrimination towards people with substance use disorders in a wide range of contexts. So healthcare, employment, housing, friendships, family. Just to take a moment to illustrate the prevalence of this stigma. So these data were collected in 2018 from a nationally representative sample in conjunction with the General Social Survey. And what you can see here is that a majority of US adults thought that people with opioid and alcohol use disorders are likely to be violent towards others, which would be a stereotype, and that they're unwilling to spend an evening with, unwilling to have someone marry into their family, and unwilling to work closely with someone with an opioid or alcohol use disorder. And these rates are all higher than when people are considering interacting with someone with depression. Stigma within healthcare settings specifically can have tremendous implications for health. So I'd like to take a quick moment to highlight some findings from providers here. So a systematic review from 2013 reviewed evidence across several studies focused on healthcare providers and found evidence that providers endorse stereotypes about people with substance use disorders, that implicit or unconscious prejudice was associated with greater intentions to leave one's job if one's working in a substance use disorder treatment facility, which has implications for job turnover and could undermine the stability of these treatment settings, and that providers who endorse more stereotypes and prejudice may be providing lower quality care to people with substance use disorders. In our qualitative work, we've been particularly worried about stigma outside of substance use disorder treatment settings. People in our studies have described striking experiences of stigma, especially in emergency medicine settings or other settings where they might need some type of pain management, like if they're having a surgery. So an adolescent participant in one of our studies was discharged after an overdose with a note from their ER doctor saying just, "Stop taking drugs because they will kill you or hurt others." And their mother, who was also a participant in our study, was furious at this doctor. She pointed out that a discharge for a different kind of health emergency involving a relapsing chronic illness would involve recommendations for further treatment, perhaps a referral. And this mother identified stigma as the reason for getting this really outrageous discharge summary from the ER doc. If we stick with healthcare settings for just a moment, we have some new data that I'm excited to share with you today. So this is from a Photovoice study that we conducted in Malaysia last fall. Participants included individuals from several key population groups and folks living with HIV. And we asked them questions including, how do doctors see you? And what do you want doctors to know about you? And participants responded through photographs and captions. So here were some of our responses from our participants who inject drugs. This first participant said that they're seen as society's garbage, that they're marginalized and looked down upon. The second participant said that doctors see them as stubborn and inactive. And our third participant here said that they needed moral support from their doctors, even if they don't look like or seem like they need that support. In this study, we were really quite struck by how participants both describe sometimes pronounced experience of stigma from their doctors, and we'll see more of that when we get into the HIV section, yet they still wanted to connect with and receive support from their doctors. Turning now more fully to targets of stigma, so this would be people with substance use disorders. People with substance use disorders experience pronounced shame, that emotional core of internalized stigma. They anticipate and experience stigma from others before, during, and after treatment. And these experiences of stigma have implications for continued substance use and for treatment access. So these are a few quotes from a recent study of people receiving treatment for opioid use disorders in Delaware. These participants experienced a great deal of social rejection, and they encountered a lot of misinformation and stereotypes about their medication. So this one participant told us that the person that they had disclosed to acted like she was Superman and I was kryptonite. She did not come near me. I talked to her one more time after that, after they disclosed. And this person said, yeah, I don't think we're going to see each other anymore. And this use of the word kryptonite has really just stuck with me. I imagine someone treating you like you're this radioactive substance that's harmful and dangerous to other people. We also commonly see substitution narratives surrounding medications for opioid use disorders. So for example, this participant's mother told them, you just traded an illegal drug for a legal drug, something that you don't have to pay for. I have to pay for it in the long run because you have state insurance and I pay taxes. Basically, I'm still paying for your drug habit. We think that these substitution narratives reflect in part some pretty pronounced stigma. Turning to the consequences of stigma and thinking about that broader literature again, we see a good amount of research suggesting that people who experience more stigma engage in more substance use. So I've been focused on stigma experienced by people with substance use disorders specifically, but I'd like to emphasize that stigma is a risk factor for substance use among people experiencing many other forms of stigma. So here are a few examples just from the LGBTQ and race stigma literatures. This research suggests that people who experience enacted stigma, so poor treatment from others based on their sexual orientation, their gender identity, or their race or ethnicity, may cope with these experiences via substance use, including alcohol, tobacco, marijuana, and other illicit substances. Stigma is related to the likelihood of use and more frequent or disordered use of substances. And among people with substance use disorders who are in treatment, we also see some evidence that stigma is associated with greater substance use. If we turn to associations between stigma and treatment outcomes, the qualitative literature seems to be pretty consistent. When we talk to people about their experiences, people tell us that when they internalize more stigma and when they anticipate or expect more stigma, they're less likely to start treatment. So this first quote is actually from a high schooler who had a pretty pronounced opioid use disorder or severe opioid use disorder. These were data that we collected up in Boston. The participant told us that they didn't want to get help because they were scared of what people were going to think in high school, because you're very scared about being judged. And, especially in high school, that people are going to talk. Qualitative results also suggest that stigma is associated with lower treatment adherence, which you see in the second quote from a participant in Delaware. And this participant said that the person that they disclosed to doesn't like me on Suboxone and told me to come down off it and not stay on it for long because it's bad for my body. After I told her, I start coming down that week. So, again, this wasn't a medically prescribed or recommended tapering. This was because a family member told them they didn't like Suboxone and they should come down off it. Our findings, though, get more complex when we turn to the quantitative data for literature. So we have some findings suggest that people who experience more stigma delay seeking treatment, but we also have findings suggesting that it's the people who are in treatment who are experiencing more stigma. We have some findings suggesting that people who internalize stigma are more likely to drop out of treatment, but we also have findings that people who have internalized more stigma stay in residential treatment centers longer. And then we have actually a lot of null findings within this literature, meaning that stigma was not associated with treatment. Several reviews of the literature that have been conducted in the last decade have concluded that findings on associations between stigma and treatment related to substance use disorders are mixed. This is really interesting to me as a stigma researcher because in other areas like HIV, which we'll turn to next, the findings on stigma and treatment are becoming clearer and clearer that people who internalize more stigma, people who experience it and anticipate it, are less likely to initiate care, to start medication, to stay in care. So again, we're going to come back to that. But if we think broadly about what this means, to me, these mixed findings suggest that there are factors specific to substance use disorders that may be moderating or changing our more general cross-cutting conceptual frameworks. And we really need to be thinking more about these moderators as we try to apply what we have learned about stigma from other contexts to substance use disorders. So these might involve things like taking into account how long has someone been in recovery, what's their recovery identity, or how do they think about themselves. It may also include or involve things like where are they, what is the legal or cultural environment surrounding drug use, treatment, and harm reduction where they are. And I hope that taking into account some of these other factors may help to clarify some of these mixed findings that we're seeing in the quantitative literature. I'll just briefly mention that we did dig into one of these moderators' time in a recent paper that just came out in Nature Reviews Psychology. And more broadly, much of the work that I just reviewed in the previous section is all summarized for you in an article which was published in American Psychologist, although it does lack the citation since 2022, or since 2020 that I shared, but a lot of it is in there. Okay, so let's switch gears and talk about stigma related to HIV. So as folks on this room know, we have accumulated a lot of research on stigma over the past 40 or so years of the HIV epidemic. Folks on this call have contributed much of this literature. And the past 10 or 15 years have seen a rapid expansion of research on structural stigma. In particular, we've seen a lot of research looking at how structural stigma related to LGBTQ identities and orientations, race, and HIV undermines HIV prevention efforts. So structural LGBTQ stigma has been defined as, studied or operationalized as same-sex marriage bans, indicators of whether states confer legal protections, such as employment and housing non-discrimination or school anti-bullying policies, as well as other policies, as well as local attitudes towards sexual and gender minorities. And this work generally suggests that sexual minorities living in places with more anti-LGBTQ policies, or even in places that don't have supportive LGBTQ policies, show worse outcomes related to HIV. And this includes less condom use, less HIV knowledge, less frequent HIV testing, greater risk of HIV, later HIV diagnosis, and greater risk of AIDS-related mortality. Thinking about intersectionality, some of this work suggests that the impacts are worse for sexual minorities to experience multiple forms of stigma. So specifically, some work suggests that these outcomes are worse for Black sexual minority men in comparison to white sexual minority men. Some work also draws attention to structural racism. So for example, Alicia Reed and colleagues found that our HIV prevention interventions are less effective for African Americans in places where there's more racial residential segregation and racism within communities. Okay, so if we turn to perceivers, so again, people who are not necessarily living with HIV themselves, evidence suggests that HIV stigma among perceivers is associated with greater fear of HIV, less knowledge about HIV, and not knowing anyone who's living with HIV. Because we now have several decades of the HIV epidemic under our belts, researchers are starting to conduct some really interesting longitudinal analyses surrounding how stigma is changing among perceivers over time. So for example, during a period of art scale up in sub-Saharan African countries, desire for social distance, which is a form of discrimination from people living with HIV, was lower in places with greater HIV prevalence, and it tended to decrease over time. So it's possible that HIV stigma is lower in environments where individuals know more people living with HIV and where HIV treatment is available. So when treatment is available, perceivers may be able to see more people living with HIV, and therefore it may become less scary. HIV stigma also appears to have negative consequences for people who are members of key population groups. We found that people with opioid use disorders who endorsed greater stereotypes about HIV thought that they themselves were at lower risk for HIV, and then in turn reported less frequent HIV testing. Unrelatedly, Golub and Gamarel have also found that men who have sex with men and transgender women who anticipate more HIV stigma delay HIV testing. We have a good amount of research on the negative impacts of HIV stigma on health outcomes of people living with HIV or our targets of stigma. And we actually have so much research that we now have at least like one meta-analysis of meta-analyses or paper summarizing other papers that summarize research. So we have a lot of data in this area, which is terrific. And the research generally suggests that HIV stigma undermines treatment and health outcomes among people living with HIV. So much of this work has focused on treatment and engagement, given its importance for the well-being of folks living with HIV. And these quotes are from one of our studies in South Africa. And in it, both people living with HIV and providers talked about anticipated stigma as a barrier to ART initiation. Participants who hadn't yet disclosed at home were worried that others would see them at the clinic and gossip about them. One participant said, the reason I hadn't started was because I was afraid, because I hadn't disclosed at home. So now I also feared going into a public space among people I know who will be talking about me at the clinic. So those are the things that made me afraid to get started. Providers also talked about how this gossip placed people, and especially women, at risk of violence from their partners. So one provider said about a woman in a vignette, I don't think she's going to start medication because she is scared. The moment you come to the clinic to take your medication, they're going to tell other people, oh, I saw so-and-so at the clinic. And then they're going to go to your exes, and then your exes can kill you because they know the rural areas, there is not much information about HIV. She is not safe. So in this study, these expectations of being treated poorly by others in the future seem to be a barrier to ART initiation. And these expectations ranged all the way from gossip to physical violence. Quantitative studies have also found associations between stigma and ART initiation. So using longitudinal data also collected in South Africa, we found that internalized stigma experienced 1 week after an HIV diagnosis was associated with more avoidant coping 3 months after that diagnosis, which was then associated with lower likelihood of ART initiation by 6 months after the diagnosis. So this was particularly concerning to us given other recent evidence suggesting that internalized stigma appears to be particularly high just after HIV diagnosis. So in that, 1 week to maybe like a few months zone, it's higher, and then it appears to start coming down. So a paper reviewing associations between stigma and ART adherence found that 71% of cross-sectional studies showed that more internalized and enacted stigma was associated with more non-adherence. Another review of the stigma and adherence literature identified 3 pathways through which stigma appears to impact medication non-adherence. So this includes mental health difficulties, reduced self-efficacy, and then concealment. HIV stigma is also associated with less engagement in HIV treatment more generally, including later presentation for HIV care and longer gaps between medical care visits. And then beyond HIV care, HIV stigma is also associated with less engagement in care for non-communicable diseases. So all of these other chronic illnesses that folks living with HIV may experience as they age. And Stockton and colleagues suggest that past negative experiences with healthcare providers, anticipated stigma in response to disclosing HIV to new healthcare providers, and internalized shame are all preventing people living with HIV from accessing care associated with these other chronic illnesses. There's also evidence that HIV stigma is associated with worse physical health overall. So some work suggests that internalized and enacted stigma are associated with lower likelihood of viral load suppression. A meta-analytic evidence suggests that there's an association between HIV stigma and worse overall physical health. Related to mental health, internalized stigma is associated with greater likelihood of depression and lower self-esteem. And then some work also suggests an association between stigma with anxiety and emotional distress. And I would hypothesize that this might be driven by anticipated and maybe enacted stigma, given that these are stressors for folks. Circling back to our Photovoice study from Malaysia, I thought I'd share just a few more examples related to HIV treatment specifically. So this first participant was a sexual minority man who said that doctors were shocked by him and looked at him weirdly when he went in for testing. So you can see in this photograph that his toes are painted. This second participant was a person living with HIV who said that they have built a protected door around themselves to hide their shame, and that doctors need to knock on this door respectfully if they want to see what's inside. And then our third participant was a person living with HIV who wanted their doctors to know that they are strong, but they also get scared of HIV and that they need help from their doctors who have more medical knowledge and can provide them with moral support. So similar to our previous photographs, you can see here that these both document stigma from healthcare providers, as well as a yearning to connect with and be supported by one's doctors. So to me, this makes sense given that doctors are a lifeline for folks living with HIV and other types of chronic illnesses. Okay, So thus far, we've been talking about stigma associated with substance use disorders and HIV somewhat separately. But we know that people living with HIV experience stigma associated with other characteristics, maybe their substance use, but also their race, sexual orientation, gender identity, and other characteristics. So before we move on to interventions, I'm just going to lightly touch on a few findings related to intersectionality. So we have some work suggesting that stigma experienced before an HIV diagnosis may shape experiences of stigma after that diagnosis. So in one study, we found that Black sexual minority men with greater internalized race and sexual orientation stigma before an HIV or STI diagnosis experienced greater HIV or STI internalized stigma after that diagnosis. So this is concerning, again, given that we know that internalized HIV stigma right after that diagnosis can be both higher overall and may be a barrier to engagement and care. Research also suggests that stigma associated with intersecting characteristics like substance use disorders and race in healthcare settings act as a barrier to HIV care. And we found that people who experience high levels of multiple forms of stigma may have worse health outcomes. So people, just for example, who internalize high levels of substance use and HIV stigma appear to have more depressive symptoms. So I think that overall, these findings are underscoring the importance of thinking about all of the ways that people living with HIV may experience stigma when we're trying to understand what their experiences are and address that stigma through our interventions. Okay, so I've been told that no stigma talk is complete without touching on solutions. So we're going to wrap up with some stigma interventions. So unfortunately, there is no one silver bullet to stop stigma associated with either substance use or HIV, but we do have many tools in the stigma intervention toolkit. In other words, we have developed a sense of strategies that do work to decrease stigma. We have tools to address stigma at that structural level, like by changing stigmatizing policies. We also have tools to address stigma among our perpetrators, such as through contact, and we have tools to address stigma among targets or people living with substance use disorders and HIV. Now, some of these tools are designed to reduce internalized stigma, whereas others are designed to help people be more resilient to enacted and anticipated stigma from other people. So I'm going to focus for a moment just on a few of these tools to spotlight a few of these evidence-based strategies for you. So if we start at the structural level, one stigma reduction tool is to aim for policy change at the federal or state levels, which I know is way easier said than done, but let's talk about it. So we can aim to repeal stigmatizing policies, and we have some evidence that health outcomes for stigmatized group members do improve after stigmatizing policies are removed. So for example, the mental health of sexual minority men in Massachusetts improved in the year following the legalization of same-sex marriage in that state. And we can also aim to enact protective policies like non-discrimination policies. So we know that non-discrimination policies are associated with improved well-being, and so passing them may also improve health. There's so much opportunity for change here, thanks to the war on drugs, historic HIV criminalization policies. We have many policies that need to change to improve the well-being of people living with HIV and substance use disorders. Behavioral design can be especially helpful for organizational and institutional settings. So there's not a ton of research evidence on this one in comparison to some other strategies, but I think that this one is just really neat food for thought. So we're going to dig in. So Iris Bonet discusses this in her book, What Works? Gender Equality by Design. So she talks about it in relation to engineering organizations and especially workplaces to limit sexism. And her whole thesis is that stigma at the individual level is hard to change. So it's hard to change stereotypes and prejudice, which we know drive discrimination. So Bonet recommends implementing organizational policies and changes that essentially constrain opportunities for stigma to influence decision-making and behaviors. So we're essentially talking about tying the hands of our stigmatizers and just making it harder for them to discriminate. One of the more classic examples of behavioral design had to do with gender bias in symphony orchestras. So historically, more men than women were hired for orchestras. There were several changes made to the auditioning process, but importantly, one was introducing blind auditions, or auditions that occurred behind a screen so that the judges couldn't tell the gender of the person who was auditioning. And after these changes were introduced, more women were hired into orchestras. So really importantly, they did not fix the stereotypes or prejudice among the judges. They just made it so their stereotypes and prejudice couldn't impact their behavior. It couldn't result in discrimination in the hiring practice. So given that changing people's hearts and minds is challenging and it takes time, this is a strategy that I'm becoming more and more interested in. Not that I know exactly how to wield it or use it, but I think it's really interesting to think about how to do this in healthcare settings, in particular, because we know how important these settings are for health equity. So Laura Nyblade has described organizational policy change, which does encompass behavioral design as one of 6 key strategies for stigma change in healthcare settings. So looking for ways to standardize procedures, including by introducing checklists, and if needed, thinking about how to restructure facilities are strategies that Nyblade and others recommend. Okay, so shifting down to the level of the individual, thinking about our perceivers, one of our most powerful ways to address stigma among perceivers, including the general population, healthcare providers, and others, is through contact. So contact is how sharing personal stories can change stigma. And we have a lot of research on this, and this strategy appears to be effective at reducing stigma associated with many characteristics. So substance use, race, HIV, other things as well. Contact can happen either in person, like when people interact and talk to each other, or vicariously through the media, such as TV, the radio, podcasts, or books. Research suggests that contact leads to increased empathy and perspective taking with stigmatized individuals. It also leads to enhanced knowledge, which can lead people to question the stereotypes that they have about a group. It also leads to reduced anxiety about interacting with stigmatized individuals in the future. And then in turn, this all leads to lower prejudice or improved feelings towards stigmatized individuals. And lower prejudice paired with those reduced stereotypes can lower the likelihood of discrimination, which is often our end goal. Of course, there are some important complicating factors here, which is why in part we observe actually so much substance use disorder stigma in families and healthcare providers, even though affected family members and providers have a lot of contact. So some of these issues have been highlighted in recent reviews. There's some really nice work from Elizabeth Flanagan and colleagues suggesting that Photovoice can be used as a form of extended contact to reduce stigma among providers. So we're actually using the results of our Photovoice study to try to reduce stigma among a group of providers in Malaysia. So providers in our stigma intervention will see the photos and captions that you've seen during this presentation, as well as some others. And we're going to see if this can help to move the needle on prejudice. This is maybe my favorite photo from the study, or one of my favorites. This participant, who is a sexual minority man, and we think a professional photographer, they said, "I want doctors to know that I want to be free of being myself around them, to spread my wings and share my experiences with them so they can help me reach the skies. But at the end of the day, I'm still human. My wigs may need tending when I make a mistake, and I know I have good doctors I can trust that can treat me without clipping my wings in the process." So I can't help but feel something every time I've seen it. So here's hoping that our providers will also feel something, because that's what we want to do. We want to change their feelings when we're thinking about prejudice. Language is another way to change stigma among perceivers. So research shows that language can spread stereotypes. So individuals described as substance abusers are seen as deserving of blame and punishment. They're unlikely to benefit from treatment. And research also shows that language that is scientifically accurate and people first, like saying a person with a substance use disorder, has been shown to promote perceptions that substance use disorders are chronic yet treatable health conditions. I'll just take a very little detour to mention that, citing this research, John Kelly and I worked with the Society for Behavioral Medicine to call on Congress to change the names of our federal institutes on addiction to take out the term abuse. So this position statement was released in 2020. I'll also mention that many others have called for this name change. So I found quotes from Volkow and even Biden calling for changes to these names in the 2000s, critiquing the word abuse. But we have an update. The Department of Health and Human Services Secretary announced that the president's budget for fiscal year 2023 proposes to remove the term abuse from our HHS agency names. So we might see some changes to SAMHSA, which may become the Substance Use and Mental Health Services Administration, NIAAA, which may become the National Institute on Alcohol Effects and Alcohol-Associated Disorders, and NIDA, which may become the National Institute on Drugs and Addiction. So something for us all to stay tuned for. Okay, so I'm going to transition us quickly back to our toolkit for a few final tools. So we can also address stigma among targets, so people living with substance use disorders and HIV themselves. I often think about bolstering resilience resources for stigmatized folks. So these include modifiable strength-based characteristics that may buffer or really protect people from the negative impact of stigma on health outcomes. And so examples include social support and adaptive coping interventions. So the idea here is just that it may take a while for stigma to change. So it's important to think about how to protect people from it while we're also working on changing it. So we really want to do both. And the last tool that I'm going to highlight or draw attention to is activism and empowerment. So intersectionality theory, which is based in Black feminist thought and which we briefly talked about earlier, is really an action-oriented theory. So when we apply it to stigma, it encourages us to not only think about how individuals' experiences of stigma are shaped by these interlocking systems of oppression, but also how to deconstruct those systems or really how to change them. And folks living with HIV have a long history of trying and succeeding at changing oppressive symptoms. So interestingly, we have some work that suggests that people living with HIV who identify as activists do better on some indicators of well-being than people living with HIV who don't identify as activists. So they tend to have better social network integration, better social well-being, they show more active coping with discrimination, and they report more meaning in life. They also report more depressive symptoms. And as someone who engages in activism, I have to say I did not find that to be surprising, but I think that is good for us to keep in mind. But I think that our take-home message here is that thinking about how to encourage and provide opportunities for activism and empowerment might be helpful for some aspects of individual well-being. And it may also help to accomplish, social change and lowering stigma overall. So we do have other tools. I think that the trick for us is to figure out how to use our tools or really implement them, because this is an implementation science challenge, in ways that make them most effective. So we have some evidence on how to do this. We know that multi-component interventions that use more than one stigma reduction tool appear to be more effective. Multi-level interventions that address stigma at both the structural and individual levels, as well as among both perceivers and targets, appear to be more effective. And then longitudinal interventions that use our stigma reduction tools over time appear to be more effective. So our bad news today is that history tells us that deconstructing stigma isn't an easy or a quick job. It's right now is a very heavy moment for both racism and LGBTQ stigma in our country. So we very much know that this is not an easy thing to do, but I hope that the good news for us is that science tells us that we do have tools at our disposal to do it. And the challenge for us, I think, as scientists, is to figure out how to use these tools to more effectively address stigma associated with HIV, substance use disorders, and all of the other intersecting stigmas that folks experience. So thank you so much for your attention. I'm really looking forward to discussion. So I'll stop sharing my screen and see if folks have anything they want to talk about.
Valerie, thank you so much. This was impressive. It was a grand tour. It was not a grand round. It was a grand tour.
Oh.
In a way, you brought everything together. So it was very comprehensive. And at the same time, you had a lot of attention for detail. So that was really wonderful. And I can imagine that people want to listen to the talk again and also look at the references that you included and For those who don't know, this lecture or this grand rounds, as all our other grand rounds, are being posted on the HIV Center website probably within about a week from now. Yeah, so thank you very much, and let's see if there are any questions. People who have questions, you can either raise your hand, you can put a question in the chat, and I will try to pay attention to all the requests that come in. A very first question is from Brian Kuttner, and let's allow him to talk, and he can, let me see.
Yeah, can you hear me?
Yep.
Yes,
Hi,
we
Dr.
can.
Kuttner.
Yeah, great. Oh, I can't put my camera on, but thanks, Valerie. That was awesome. I was nodding my head and smiling the entire time. It was just a pleasure to hear you talk and a pleasure to learn more about stigma. And my question is about, it's about intervention. And you mentioned it's an implementation science question in the end, because we're trying to, in one of our projects, we're trying to figure out like, what's the set of tools that people could implement in a healthcare setting to reduce stigma.
Mhm.
And it doesn't look like there's like, you know, a single curriculum or, you know, like a take off the shelf guide that someone could just implement in their setting. As far as we can tell, there are these like, there's a set of things that seem to work that you pointed to. And I'm just wondering what the recommendation is for these healthcare settings that are on the ground trying to do something. And the low-hanging fruit is, you know, they can do a workshop, but it's not, it may not really be multi-level or longitudinal. And I just wondered what recommendations you have for that.
Yeah, that's a great question. So we're working with healthcare settings in Malaysia to try to move the needle on stigma within their healthcare settings. And I more and more think about stigma interventions. I'm not a car person, so this could be a terrible analogy, but like, do you want the Cadillac of stigma intervention? Do you want, here's everything we know about it? I agree with you. There doesn't, you know, Laura Niblate's done some nice work on stigma interventions in healthcare settings, but even that you would have to do like a good amount of adaptation or really think through how might that look in like in a US setting. I know much of that has been in non-US settings, or adapt. Brian, I know you focus on some other types of stigmas. I think most of her work is HIV stigma. So when I am talking to healthcare settings, I use this toolkit idea and I say, here's a variety of things that we know works. We also know that like the Cadillac version of this is going to be a multi-level intervention where you're looking at the policies in your healthcare setting and you're thinking about your doctors and you're thinking about your patients. You're also thinking about your receptionists. You're thinking about everyone. And you're doing this over time. You're thinking about using a lot of these different tools. And if the number one priority of a healthcare system is to address stigma, maybe they can implement this Cadillac version of it. But the reality is, I think, or the reality has been from some of my discussions of like what is feasible to do within this setting, given, you know, the juggling of lots of different priorities. And so I think what you end up with is maybe sometimes the Honda of stigma intervention. But, you know, I think what happens, you know, what you can see in the literature when we look at the findings of when a healthcare setting decides, well, we can't do the Cadillac, we can't do something repeated over time, you see these one-off workshops and they just don't work over time. You know, they yield like a blip of changes in maybe knowledge. And then if they are followed over time, you often don't see those lasting effects. So I think that, you know, it's a tough conversation around here's what we know works. In terms of the tools, again, Brian, I think that's a really important point that you're making around like, we don't have like, here's your curriculum, go at it, but here's like the variety of things that we know. And if we do more of them, involving more stakeholders over a longer period of time, we would hope to see more. But bumping up against reality, I think, is the challenge. I'm not sure if that answers your question, Brian, but I think it was a great one, and thanks for asking it.
Thank you. Thank you.
Well, there are more questions, but I would like to follow up on a question that Brian asked. So if there are no concrete programs in the healthcare setting, just here's the program implemented. You said, well, that is the case. And at the same time, we know a lot about what works. Does that mean that you would recommend in the healthcare setting to make use of these strategies that you have identified that work in general, like in contact, and basically use them as building blocks for a multi-level or a multi-component intervention?
Yeah, thank you so much for asking. Exactly. So for example, for what we're doing, we're looking at how can we know that education-based interventions are also very helpful, especially in places where there is pronounced stigma, a lot of stereotypes. So we're looking at how do we integrate education, contact, changing norms, and like an eye towards policy change. And we're trying to roll that out. I think of this, is it the, now I'm going to show off that these are not my expertise. Brian and I, we went to a symposium at SBM focused on this very thing. Is it the MOST design, Brian?
Yes.
Yeah, I think about
By
that.
Linda Collins.
Yes, thank you, Brian. I think about Linda Collins' work with the MOST design frequently in relation to this. I think it'd be really interesting to see studies around like, when do people, because it's also the case that different perceivers may need different things, even if we're focusing on that, or different targets would definitely need different things, right? If you're thinking of a target of stigma who has no internalized stigma, none, but they anticipate a great deal of stigma, they need a different intervention than someone who is internalizing a great deal of stigma and hasn't told anyone in their lives about what they're living with. And so there's no stigma to anticipate. So I think most designs actually carry a lot of promise for thinking about how do we like combine our tools for different groups of people, and what are the right combinations of tools. So hopefully that, would love to see that. I think it'd be interesting.
Thank you. The next question comes from Lucy Liotta. And here is the question. Lucy, go ahead. You have to unmute yourself. We don't hear you, Lucy. At least I don't.
Teo, I think I must be listed as Lucy because it's Claude.
Valerie, this is Claude Mellons.
Oh, hi.
Hi, Valerie. I'm so sorry. I'm realizing Lucy works with me. I don't even know if she's on this, but set this up for me. So is it my turn to speak? Because yes, I'm not hearing Lucy. So
go ahead.
Okay. Oh, I got it to work. Okay. Hi. It's nice to see people and you're presenting. That was fabulous. And I just want to say ditto to what Teo said at the end. And I think we all really appreciate that here as we try to take on stigma across multiple areas. And I've been trying most recently to do it around mental health. But I guess I have a question for you. Given everything that you've said, which I completely relate to in terms of, there's not one causal pathway, there's not one factor, there's multiple levels of intervention that need to happen. There are, so many different factors. I guess I'm going to push on a different level. Is there a collective response? I know NIH is going to hear this, but is there a collective response to working with our research funders that maybe our models that are easy to do in a simple study with like a workshop or 3 sessions of an intervention are really wrong, and we need these multi-pronged models that may not be so easy to evaluate? I guess I'm just asking, do you have any thoughts from an advocacy perspective on research, not just service, but how to evaluate the multiple things? It's taken, hundreds of years to create many of the stigmas that you're talking about, and 4 decades of HIV, and we're not going to eliminate it with simple interventions.
Right.
Did that make sense what I said?
Oh, yeah, absolutely. No, I'm smiling over here because I'm like, yes, exactly. So I think it's great. I hope NIH folks listen to this because I think that they're on board with this. 2 summers ago, they had like a expert workshops on like intersectional HIV stigma, and I was part of one of the methods workshops, which was really about measurement. But there were intervention groups, and this was a big part of our conversation. If you want us to make meaningful change on these stigma processes, which we know are multi-level, such a great point. These have been built over centuries. These are deeply ingrained in like human psychology, human sociology. These stigma processes like exist for a reason. Otherwise humans wouldn't do them. And so to try to be like, we're going to get rid of stigma in a 5-year grant project is a bananas expectation, right? And so we did. I mean, there were conversations around what could grant mechanisms look like that could better support this work. I mean, it is kind of interesting to think about because what we're really talking about is how do we leverage NIH funding to do like broad social change work, right? And so that's a really interesting thought experiment. And so I don't think it's news to any of our program officers. They're quite well versed in stigma, but it is an interesting thing about how do we do it. So when I'm being gentle with myself as a stigma researcher, I think about we are all working together. We are all cogs in the wheel, and I care. I'm like really in the weeds often of like how are targets experiencing stigma? How does that change over time? How does it impact their health? And then we also have other cogs in the wheel who are like thinking deeply about structural stigma. And when you look at all of us together, I feel like we're doing some really neat things in terms of understanding. And so when I'm being gentle with myself, I say, okay, no one project can do any of this, but if we're looking across our portfolio of shared work, we're doing some neat things. Other times I'm like, this is a disaster. We have a lot of money and a lot of really smart people working on sexual and gender minority stigma. We've seen so much change. Like even in the time paper that we just wrote, we wrote it mostly in 2021, and we said, look at all this great change for LGBTQ stigma. And then this year feels like such a disaster. So it's such a slippery concept that moves back and forth. So when I'm not feeling easy on myself, I both feel like we should, within these one interventions, be trying to do more. And, where is our scope of influence? This is not. So another solution that came up is like, not only like, do we need longer interventions, we need more funding to support like scope, like reaching like, broader levels, but we also need more real support for community engaged work, because that's where like the successful social movement, social change can come from. And also we need to interact with policymakers. So we need things that not only take us to policymakers, but let's bring policymakers to us. And so how can we open up that communication so that we can influence some of these like structural level issues like a little bit more directly? That's such a great question. And I'm glad I'm not the only person who might be like staying up at night wondering.
Thank you. No, I get stuck.
Yes.
It's sort of like, it's so much. And, yeah. Anyway, thank you.
It's interesting to see how much money is available to test the impact of a medication. Huge projects are being set up to do that, while stigma is so much more complicated to address and to test whether something works or not, and there is much less money for something like that.
Yeah, and then people don't appreciate our science as much because we're doing. I always tell my my students studying research methods that we're doing the hardest science there is. We're studying. I tell them this. We're studying humans. But yes, so even if you get to this medication, if you get to whatever, if people aren't going to take it because of stigma, then what's the investment for?
Yeah, so maybe we should do the Valerie of the maybe we should call it the Valerie drug against stigma.
then no one will forget.
Any other questions? If not, Valerie, I have a question about intersectional stigma,
Sure.
and I'm glad that you paid attention to that and how you did that. Of course, the challenge is always with how to measure it and how to measure the impact.
Yeah.
And what I noticed that in your presentation, basically you made the decision, well, I focus on two.
Mm-hmm.
And I was wondering whether you think that that is the solution to assessing so quantitatively assessing intersectional stigma, and that in a way we are not able yet to look at more than 2 or 3 different kinds of stigmas at the same time.
No, I think that there's a lot of different ways to do it. So if you wanted to, and I think that the question of intersectional stigma measurement is a tough one, because bringing together our measurement tools with the theory is very tricky. But I also think that if we nest our questions of how do we measure this within our research questions, sometimes I think that starts to crack open different strategies. So for example, we were interested in how does stigma associated with like race and sexual orientation shape experiences of HIV stigma post-diagnosis. So we measured those 3 separately, actually, with Lisa Eaton, who was here a few weeks ago. So we did use parallel measures of intersectional stigma to look at that. But Aidan Scheim and others have argued that it's tough for people to differentiate between the reasons why they're experiencing stigma. And so they've developed, nice measures like the INDI, the intersectional discrimination measure, which just says, because of who you are, what are you experiencing? And so that gives you, theoretically, this measure of intersectional stigma associated with everything you're experiencing. Or you have approaches like the everyday discrimination scale, which is also what are you experiencing, but then asks people to say, why did you experience that? And then you can look to see, well, do people who experience this type of stigma, does it look different? Do their outcomes look different from that? So you've got these parallel measures, you've got these more measures that are sort of cross-cutting. And I think for me, it's been, there are pros and cons of each when you consider them in relation to the theory. And so I always think what makes sense in terms of the research question that I'm asking. So if I am really asking, and I think that those other researchers could definitely critique me. I think that they could say it's never appropriate to ask people to separate out their identities. But my research question is, how does one experience of stigma shape the experience of others? And I'm looking at one type of operationalization. We're actually, AJPH I thought it was coming out in May, maybe it's coming out in June, going to do a special issue on intersectional HIV stigma. We actually have a methods paper in that. And we call on researchers to think about the multidimensional aspect of stigma, which is this. So, people are experiencing multiple dimensions of stigma, but also intersectionality encourages us to think about this multi-level issue. So how can you think about intersectional stigma occurring beyond the individual level, but maybe, people existing within different forms of structural stigma. Intersectionality also encourages us to think about stigma in a multi-directional way. So like, how is it changing? How is stigma at one level impacting stigma at another level? And then, as I mentioned, it's an action-oriented theory. So if we take a step beyond just measurement, intersectional stigma approaches would really encourage us to think about what are action-oriented ways, like participatory action research or other things, to be approaching our stigma question. So I think by bringing intersectionality to the question of stigma, like research methods, it cracks open so much that we can think about in terms of our methods. I'm not sure how satisfying that is because there's not one answer, but I think about it a lot. I think it's a tough question for your research design. What's the best way to get at this?
Valerie, your answer is inspiring.
Oh, no.
Ruben Robbins. Oh. doing the right thing. I'm sorry.
Can you hear me now?
Yes, Ruben, we can hear you.
Okay, sorry. Thank you. That was a really great talk. Hi, Ruben. I'm an investigator here. Stigma is not my main area, but you said something a few moments ago during the discussion that really intrigued me. You said stigma, humans have developed stigma we've had this for a very long time, and it makes me think of, is there some evolutionary kind of component to it? And then I said, well, to what extent do our stigma prevention interventions incorporate this kind of idea that humans have been living with this ability to do this for, well, gosh, maybe tens of thousands of years? What a hard behavior to change.
Yeah. Love this question. So in my, I'm squarely not an evolutionary psychologist, but I do that deep
Neither
dive.
am I, so.
Yeah, squarely not. But there are evolutionary psychologists, Kurzban and Leary, who have written on why does stigma exist? And their theory has informed some of the categories that, for example, Phelan, Lincoln, Davidio have put forward. So it's mostly clumped as existing to keep people down, away, and in. So keeping people down are oppression mechanisms. So some people in society have more power than others. So when we're thinking about racism and sexism, that's keeping people down. Humans have done this forever. Keeping people away is our disease avoidance mechanisms. So Kurzban and Leary especially argue that we have these parasite avoidance like processes that lead to like a disgust reaction when we think that someone has an infectious disease that can harm our own health. And importantly, they say that this is like an overly sensitive mechanism, right? So we feel disgusted by people who won't harm us at all, like that aren't contagious to us, but it's just safer for humans to avoid folks who may be. So that's HIV, that's like all of our illness stigmas, or a lot of our illness stigmas, even ones that aren't actually contagious, but just because that lever is so sensitive. And then keeping people in is how humans keep an eye towards our social norm boundaries. So they argue that we have evolved ways to say, here's what's normal in society. And when you step out of that, we're going to stigmatize you in hopes that you're going to step back in. So that is substance use disorder stigma, LGBT stigma, sex work stigma. And the great irony of that one is it definitely doesn't work, because we know that, if you look at any of these literatures, but I think that the weight stigma literature in particular has done a really nice job showing that if we stigmatize folks who have higher, weights, that they do that, they're not going to engage in behaviors that will lead to weight loss. It might actually be the opposite. So those are the three, keeping people down, away, and in is what those evolved mechanisms look like. And this is part of the reason why I think why I struggle actually with intersectional stigma measurement. Sorry, now we're doing a deep dive into my brain, but you can kind of like those different mechanisms invite different behaviors, right? So like keeping people away mechanism might look different than some of the others. So anyway, I don't know that our interventions really dig deeply into this idea beyond, we do know that like our HIV stigma interventions think a lot about how do we dispel fear. And I think that does really nicely map onto this like keeping people away, parasite avoidance mechanism. But that's probably the best example that I see of interventions that are thinking about why does the stigma exist evolutionarily, and how can we dispel that within our intervention. So that was probably a lot of extra thinking. So I hope I answered your question, and if I didn't, let me know.
No, thank you. I think it's just really fascinating because, just what's going on in our society today with politics, there's so much of this. And in some ways, the sort of whatever evolutionary components of it serves some purpose, because that's where I'm struggling with, because in some way you have to say this is the norm, right? Like at least politically, it's normal to follow the rules. We want that. but then you have people pushing those boundaries. And so how do you deal with that? Like without stigma in a way. And I think we're challenged with that right now socially, because, you know, you're either like some extremist, you know, right winger or, you know, snowflake liberal. And so it's very hard to deal with that. Anyway, thank you. That was very good answer.
No, that's one of my favorite things to think about.
And a very interesting question. Valerie, you can see Brian now.
Yes.
Brian, go ahead.
I had a previous question, but actually Ruben's question sidetracked me. So sometimes I have seen like calls to action for, you know, a stigma-free health facility or eradicating stigma. And it has struck me also as like, is that really possible? Because as you just pointed out, and Ruben's question pointed us to, like, it's been with us for a very long time. And if there's a power differential, isn't stigma just a process by which people can grab onto power and remove other people from power? And we're not an egalitarian society, and I don't know, even in societies where there is more equity between different groups, there probably still is stigma. So what really is the goal in the end?
Yeah, I mean, maybe the goal is just making it a little bit better for these kids in like Florida and Texas to get healthcare. just a little bit better for everybody all the time. I think it is really interesting. I mean, it'd be interesting. I'm not an expert in just like the science of like goal communication. What does it mean to set a goal? And like, are people going to get excited about like, let's make it a little bit better for kids versus like, let's get rid of it. Like, what's going to fire people up and get people on board? As a stigma researcher, I would think, sure, you know, we're going to do this intervention. And or even like as a teacher, I mean, I taught a substance use disorders in the family class this last semester, and the last comment that someone made in my class this semester was about how like much choice people have, you know, when they have substance use disorders and treatment. I was like, this is the worst way to end the class. But despite that ending, there was tremendous stigma change among those students over the course of the semester. So if my goal had been zero stigma in my class, I mean, I never would have made it. But I think it's a question of I think I'm not sure if it's a reasonable goal to say zero stigma. I don't know. I would like to think that it is. I mean, let's think about other historical examples. Are the Irish stigmatized anymore? As an Irish person, I would say no, but not in the US, but there was a time when the Irish were tremendously stigmatized. So I think we actually do have historical examples of some groups shedding it, but there are others that seem much harder to like remove. So I go back and forth on whether it's a reasonable goal, but from a communication standpoint, I can see why people are like, you know, maybe it seems more motivating for folks to say, let's get rid of it versus let's try to get rid of a quarter of it or something. Brian, I'm sure it doesn't feel.
My question kind of painted me as a cynic, but that's not really, I'm smiling. So obviously I'm not really a cynic, and I'm so eager to hear your thoughts about this. So I'm clearly not a cynic. It makes me think about stigma as a fundamental cause of disease, that construct, and that, like you said, there are different groups of people who previously were perceived as racial groups, so like Irish, Italian, who are now perceived as white, but we still have racism. So it's like you sort of like we tamp down on one thing and like expose people. There's contact. Irish people and Italian people get integrated and assimilated into American culture, and then that goes away. But racism toward Black people, that, you know, maybe it has shifted in significant ways institutionally. Slavery doesn't exist anymore, but we have these other institutional forms of racism that continue. And so that's the cynicism that's behind this, is like what you mentioned too, like ultimately what is going to take care of this, and what Claude mentioned as well, like our NIH studies are not really getting to this in the way that we think is necessary.
Right, right. And this is the other reason why I go, right, you know, you have some stigma researchers who are very much on the camp of, you know, we should only focus on the social structures and social organizations and power. Like, we should be putting all of our money there. That's it. And then for me, I agree that we should be spending a lot of time and effort there. However, what if we don't fix it? Because we're not doing the best, like, we can argue that we're not doing the best job. And what does that mean for the folks who are like in the burning house while we're all outside trying to put out the fire? You know, can we like do something for those folks while we're trying to solve the broader issue? And that's why I think that these multi-level approaches are important around how do we think about chipping away at the structure while we are protecting people who are being harmed by it. And I mean, ultimately, the more that we get rid of internalized stigma at the individual level, those folks go out and change it at the structural level. So I think that these are really tough issues without easy solutions. We all have lots to do within our careers, Brian.
Valerie, there's a comment in the chat from Susie Hoffman. She writes, I hope we can keep our focus on the ways social structure and social organization, especially power relations, rather than evolution, shape stigma processes.
Yep, I totally agree that I think that, you know, all of those things are at play. And I think, you know, as I was mentioning, that there's a lot of stigma researchers who really make the argument that we need to stay focused on power dynamics of these social structures issue. And the danger of focusing on the evolutionary aspect is that it makes it feel like it's hardwired, that it's something that we're going to do definitely. And it's not, because it's a social process. It's something that humans have made up, and it's something that humans can unmake up. So I think that that's a really important thing to bear in mind.
Valerie, this is the right way to end the session, I think.
Unmake up stigma.
And hopefully aspirational. So thank you so much for the presentation. It was really an amazing tour, including so many different aspects with a lot of detail as well. It was really wonderful. Thank you so much, and I hope we have you back sometime soon. Everybody who participated, thank you so much, and we hope to see you again on June 2nd. Thank you, and have a good weekend. Take care. Bye-bye.
Thanks, everyone.
Bye-bye.
Thank you. Bye.